that these accessory are more caudal. Okay? So now we switch gears a little bit.
Can I ask a question about that slide? Why is B black and B and C white?
Why is who what?
B is black.
T with Z?
It's B.
Boy. Oh, because, okay, B, okay, that's a good question. C is mostly is cells, and they have pretty direct connections with the inferior parietal lobule, okay? B, we just went through an elaborate thing of what? Whole bunches of fibers interlaced among the laminae of the LGB. Some of them are coming contralateral, some of them are coming ipsilateral. So even though it's a nucleus, it has a whole bunch of fibers embedded in it. If you go and you look at a lot of the slides where you look at the VPL, the ventroposterior lateral, you're going to see this sort of speckled appearance because the fibers have to get somewhere. That's why. And again, these fibers are what? Those ganglionic fibers are among the most heavily myelinated fibers. Okay. Okay. So I forget where I am. I think we'll start back over there. Speak up.
Isn't that the longitudinal fissure?
Longitudinal fissure. Very good. Let's get easy here.
Superior frontal gyrus.
Superior frontal gyrus, middle frontal gyrus, inferior frontal gyrus. What's happening here? Lateral sulcus, very good. And then we have the beginning of the temporal lobe, but like I pointed out, this is mostly medial because it's olfactory, it's so rostral. Okay? Be specific.
Head of the caudate.
Head of the caudate nucleus. High in the back. Yes?
Lateral ventricle.
Be specific.
The head of the lateral ventricle.
It's not called the head of the it's called the, what is the most rostral part of the lateral ventricle called?
The anterior horn.
The anterior horn of the lateral ventricle. Very good. Okay. Okay. All right, we're back here. So again, what is this? Anterior horn of the lateral ventricle. What's this? The head of the caudate. What's this? Internal capsule. What's this? What is it? Putamen. What's this? Very good. What's this? What's this? And what's this? Insular. Remember that? Right up I did medial to lateral. So you can march through most of the telencephalon and literally, you know how big your frontal lobes are? You can basically see this orderly progression of all of these structures from medial to lateral. So you know that's where those structures are. So now if you look at an fMRI scan and you see a big hole somewhere, you have a fairly good idea of what is getting affected. What's basically going to happen is up in the frontal lobe, you see all of this stuff centered, and what eventually will happen is this stuff will get pushed to the outside because we will have the emerging diencephalon coming in. Okay? So we see the lateral sulcus here, and now we can see a superior, middle, and inferior parahippocampal gyri here, okay? And back over there, what is this nucleus?
Cingulate gyrus.
Cingulate gyrus, very good. Okay, we're back in the corner over there. Hi. Okay. So all of a sudden, this is a new fiber tract coming in. What fiber tract is that? The what? The anterior commissure. Remember, the anterior commissure originates in the amygdala and medial temporal lobe, and it basically comes to the midline to do what? To do the commissure, and it's bent a little bit forward. So we're not quite at the amygdala yet, but what we're seeing is the anterior commissure as it's coming together. So again, we still have the anterior horn of the lateral ventricle, the caudate, the internal capsule, we have the putamen, and now we have another structure right here that is like a piece of pie between the anterior commissure and the internal capsule. What is this structure?
Globus pallidus.
Globus pallidus. The globus pallidus and the putamen, we both can see, is lateral to the internal capsule. What do we call that collectively?
Is it neostriate?
What is the globus pallidus and putamen lateral to the internal capsule? What do we call that collectively? No? The lenticular nucleus, right. So now I'll give you a chance back there. You're raising your hand. You have the putamen and the caudate that are morphologically alike, and we call that the neostriatum. And we call the caudate, the putamen, and the globus pallidus, collectively we call it either the basal ganglia or the corpus striatum. So that's where the 7 terms come in, and different people are going to use different portions of the terms at different times, and you will now know what the distinctions are. Okay? So again, you have the globus pallidus and putamen, external capsule, claustrum, extreme capsule, and then you can see the larger insula coming in off that forked tongue of the lateral sulcus. Okay? What nucleus do we have emerging here deep in the parahippocampal gyrus?
Can't see where you pointed. Is that the? I don't know. Oh, parahippocampal.
The amygdala, because we're still a bit rostral. Remember, it'd be the amygdala because what did I tell you? The anterior commissure would be coming on either side. Okay? Give you an easy one.
That's the corpus callosum.
Corpus callosum. Okay, very good. All right. All right, now we had another structure when we saw the anterior commissure come in. What do we have here?
Optic chiasm.
Optic chiasm, optic tract, optic nerve, okay? And what blood vessel would we have here?
The middle cerebral artery.
Mostly the anterior cerebral, because you're looking at it as it's coming in towards you. Middle cerebral, remember, will be running through mostly running through the central sulcus. That's a little bit further back, okay? All right. So just on continuing on that, what is this now?
The optic tract?
The optic tract? Okay. The optic nerve. What information does it carry?
The information from the retina?
Of what?
Of
So if I say the left, the left optic nerve,
yes.
it's carrying retinal information from the,
From both eyes, but from the same.
No.
Isn't it?
the left optic
'Cause it's
nerve
after the chiasm.
is carrying it from just the left eye. Then we get, look. Then we get to the chiasm. What happens at the chiasm? The medial portions of each of the optic nerves decussate, right? The lateral portions do not. So now, the left optic tract is carrying information. What kind of information?
Visual information. If from after the chiasm, it's carrying like 50% information from the ipsilateral eye and 50% information from the contralateral eye.
Right. And now how will we talk about that? We won't talk about eyes, but we'll talk about what? Functionally. Visual
Visual field?
fields. So it's carrying information from, so the left optic tract is carrying information from which visual field? It's carrying it from the right portion of the nasal hemiretina and the left, so it's coming in from the left visual field, okay? So that's how to begin to think about that. All right. Then, of course, here, what's this?
The anterior commissary.
That's the anterior commissure cell. Okay. Now, how will you differentiate this from this? These two areas, or these two areas, how will you differentiate them? How will you differentiate those? Look at number 9. It points at here and it points at here.
Externa and interna. It's a globus pallidus externa and interna.
Zona interna and zona externa. Okay. What can you tell me about the zona externa of the median of the globus pallidus versus the zona interna of the globus pallidus?
Interna gets direct input, and the externa gets indirect input.
And where does the externa and interna go?
The VA and VL.
Which one? Zona externa or zona interna goes to, which one of those goes to VA and VL? Which one of those goes to VA and VL? Anybody?
The interna?
Huh?
Interna?
The externa. And where does the interna mostly go?
Subthalamic.
Subthalamic nucleus. Why should you be happy that the globus pallidus zona interna goes into the subthalamic nucleus? Have you finally gotten out of the infernal loop that I taught you for weeks about the striato, the lamo-cortical system just going around and around, and it seems like you never get out. But you get out through the subthalamic nucleus, okay? And this is why the subthalamic nucleus is the primary place for neurosurgery, and especially deep brain stimulation for what kind of disorder? Parkinson's disease. Because otherwise you're frozen in this perpetual obsessive